This tutorial is on another aspect of sodium physiology where the plasma sodium is very high, more than 145 millimoles per liter, and it's about hypernatremia, what causes it, and how to manage it. Hypernatremia. In this tutorial, I'm going to discuss hypernatremia, hyperosmolality, and the treatment of hypernatremia. Let's start with a clinical scenario. You're called to the emergency room to see Emily, who is 43. She presents with confusion and disorientation, but no specific physical findings. So you do some labs, and on her labs, her plasma sodium is 159 millimoles or milliequivalents per liter. So Emily has presented with symptomatic hypernatremia. So let's understand the problem. Hypernatremia is a problem of too little water in the body, or too much sodium in the extracellular space, or too little water relative to sodium. How can that occur? If you look at this model of water and sodium in and water and sodium out, and in between the serum sodium and the serum osmolality, if you have inadequate water intake or excessive sodium intake, you may get hypernatremic. There will also be hypernatremia caused by water loss in excess of sodium loss or excessive water loss. Hypernatremia due to pure water loss occurs due to excessive evaporative loss. This can happen in surgery, for example, with a patient whose abdomen has been open for many hours or their thorax has been open for many hours. A lot of water will evaporate off the exposed surface area. We also see this a lot in burns. Burns have huge evaporative losses. If you're sweating a lot in a very humid climate or during rigorous exercise, a lot of water is lost in relation to sodium. And finally, patients on mechanical ventilation who do not receive humidified gases will lose a lot of water insensibly. The other way water can be lost is from the kidney. This can occur due to absent or ineffective antidiuretic hormone activity. For example, central and nephrogenic diabetes insipidis, about which later, or due to water loss from diuresis, particularly osmotic diuresis. This can obviously happen iatrogenically with the administration of mannitol, but we also see it with hyperglycemia and all kinds of diabetic emergencies. Renal water loss also occurs where the tubules are dysfunctional, and you'll see this after acute kidney injury where patients become polyuric inappropriately. It's seen with hypokalemia due to destruction or damage to aquaporin channels, and we also see it in a similar manner with hypercalcemia. So the first thing you need to do when you see a patient who's hypernatremic is you need to assess their volume status. You'll look at your patient. Are they edematous looking, or is everything just sunken in? So is the patient dehydrated looking, or are they edematous looking? Or are they neither, which is sometimes the case? The dehydrated patient likely has fluid loss that's renal or extrarenal. If the patient is edematous looking, it is likely an iatrogenic issue. The patient has either had too much liquid containing salt, usually isotonic fluids, or has sodium overload from getting a lot of sodium in antibiotics when we're repleting electrolytes, or as part of a resuscitation strategy with sodium bicarbonate or sodium citrate in, for example, blood products. To put these into perspective, patients with hypernatremia may have normal body water, that's type C here. They may have low body water, they're dehydrated, or they may have high body water, they're hypervolemic, and that's type D. Now, a lot of clinicians out there incorrectly believe that all hypernatremic patients are type B, that they're hypovolemic and they need lots of free water, as they call it. If this patient is category C or D and you start giving them lots of water, well, this is not a good option because you're likely to cause problems with edema and hydraulic fracturing of the interstitial space. And indeed, if you work in the ICU, you're far more likely to encounter a patient with hypervolemic hypernatremia than hypernatremia caused by dehydration, with the exception of neuro-intensive care. In this situation, our patient has a sodium of 159, so we need to look at both blood and urine. On the blood side, we need our electrolytes, our glucose and urea and osmolality, and on the urine side, urinary osmolality and urinary sodium. If the patient is dehydrated and hypernatremic, what would you expect the urinary osmolality to be, high or low? Well, of course, the osmolality should be really high because the patient is trying to hold on to water as much as they can, and that osmolality may be over 1,000 milliosmoles per kilogram. Typically, the urinary sodium is so very low, and if you look at the electrolytes, all of the electrolytes tend to be high: sodium, potassium, chloride, calcium. The urea tends to be very high, and the osmolality tends to be high. So that's the picture of dehydration. Emily, with a sodium of 159, is dehydrated, so she needs to be rehydrated, and we need to figure out the body water deficit. Her body weight is 70 kilograms, and there is a formula for calculating this out, and that is the percentage body water times the weight in kilos multiplied by the current sodium minus 140, that's the normal sodium, divided by that 140 again. The percentage body water is different between men and women. So let's work that problem. For women, the body water is 55%. So it's 0.55 to multiply by 70, multiplied by 159, her current sodium, minus 140, the desired sodium, divided by 140. And if you calculate that out, you can pause the video right now and calculate it out. The result is 5.2 litres. Now, just to point that out, for a male, that will be 0.6 rather than 0.55 for women. Now, the easiest way to replace this water deficit is to give her water orally or nasogastrically. Sometimes, and it's often the case in our practice, the patient isn't able to drink a lot of water and we have to give water intravenously. And the way you do that, of course, is to give dextrose, because there must be some osmoles in that fluid or else it will cause red cell lysis. So to calculate the change in sodium per hour when you're looking at patients to whom you're giving intravenous fluid, there's a very straightforward calculation. The change in sodium per litre equals infusate sodium minus plasma sodium divided by total body water plus 1. Now, what's that 1? Where does that come from? That 1 is the litre of fluid that you have added to the patient's body water to do the calculation. For most patients, the rate of correction should be around 0.5 millimoles per litre per hour. That's about 12 millimoles per day. I will point out that the formula that I've given you really is only suitable for simple dextrose and saline solutions. It gets very complicated when you look at balanced salt solutions because there's so many different osmoles in those fluids. So we're going to give 0.45% saline to Emily, and the sodium content of this is 77 millimoles per litre or 77 micromoles per mil. Just to remind you of the calculation, the change in sodium per litre. So this is per litre of the fluid that we are giving her, is the infusate sodium minus the plasma sodium divided by the total body water plus 1. And that's that litre. So in this situation, our calculation is 77 minus 159. That's 77 is what's in, that's the sodium in 0.45% saline, minus 159, her sodium, multiplied by her body water, 0.55 times her weight, 70, plus 1. And that works out at minus 82 divided by 39.5, or minus 2 millimoles per litre. So 1 litre of half-strength saline will drop Emily's sodium by 2 millimoles. Of course, we need to put structure on our therapy, and we wish to correct at 0.5 millimoles per hour. As a consequence, we know that 1000 divided by 2 is 500 mils, and that will correct at 1 millimole per hour. And 500 divided by 2 equals 250 mils per hour to correct her sodium at 0.5 millimoles per hour. Quite a lot of fluid to achieve that goal, but at the same time she does need to be rehydrated and resuscitated. To correct at 0.5 millimoles per hour, how much dextrose 5% do we need to administer? Sodium is 159, and we're going to get 5% dextrose to correct at 0.5 millimoles per hour. Let's work the problem. So Emily's sodium is 159, and we're going to use 5% dextrose. That contains no sodium. So the change in sodium is minus 159 because there is no infusate sodium, divided by 0.55 times 70 plus 1, and that works out at minus 4 millimoles per litre. 1 litre of dextrose corrects minus 4 millimoles. 1000 divided by 4 is 250 mils per hour to correct 1 millimole. To correct by 0.5 millimoles, you'll divide by 2, which is 250 multiplied by 0.5, or 125 mils per hour. So on the surface, it would look like we should use 5% dextrose because you'd need less fluid to achieve the same goal. But remember that hypernatremia in this particular setting is a laboratory sign of low water status, and Emily has a water deficit of 5.2 litres. Assuming that she loses no fluid during resuscitation, which she will of course, using 5% dextrose at 125 mils per hour, it will take 42 hours just to correct her water deficit. If you use hypotonic saline at 250 mils per hour, it takes half that length of time to get the patient resuscitated. A point that you really must consider when you're treating these patients is that you want to correct both the water deficit and the hypernatremia. Although 5% dextrose is very effective at correcting sodium deficit, it is also very inefficient for correcting water deficit. The volume that you would likely have to deliver to resuscitate Emily quickly would correct her plasma sodium too fast. Now, any hypotonic or partially hypotonic fluid that you might use in your practice can be used for correcting sodium in the dehydrated patient with hypernatremia. This is just for reference sake in case you ever are interested. The rate of change per litre in a 70 kilo female with a sodium of 159 is approximately 4 millimoles negative for dextrose, minus 3 for Maintalite, minus 2.2 for hypotonic saline, and minus 0.7 for sodium lactate solutions. For isotonic saline solution, there will be no correction at all. This is a rule of thumb that you may or may not want to use. An 80 kilogram male has a body water of 48 litres, and this is really rough. I just want to point that out. For every 1 millimole per litre increase in sodium, there is a 350 ml water deficit in a dehydrated patient. So if the sodium is 150 millimoles per litre and the patient is dehydrated, the water deficit is approximately 3.5 litres. We want to reduce our patient's plasma sodium by 0.5 millimoles per hour. And remember, this is very rough. And what you need to do then is, if you're using dextrose 5%, you administer 15 mils of 5% dextrose per hour per 1 millimole increase in sodium. If you're using 0.45% saline, then you need 30 mils per 1 millimole increase in sodium per hour. In the situation of our patient with a sodium of 150, that works out at dextrose 5%, 150 mils per hour, and 0.45% saline, 300 mils per hour. What about hypotonic balanced salt solutions or 0.45% saline with KCl? Well, you need to be careful here. It's all about osmolality. Maintalite, which has a sodium of 20 millimoles per litre, also contains 20 millimoles per litre of potassium. These are all active osmoles, and they should be taken into account when correcting a hyperosmolar state. So the change in sodium per litre is the infusate sodium plus the infusate potassium minus the plasma sodium divided by the total body water plus 1. So for example, if you're using Maintenolite for an 80 kilogram male with a sodium of 150, then you need to give 216 mils per hour to reduce the sodium by 0.5 millimoles per hour. It's not much different from 0.45% saline. Now let's move on and visit another patient. Adrian is 70 years old, and 4 days ago he had an open abdominal aortic aneurysm repaired, and now he's doing well and he's in the high dependency unit, or the ICU. He has a sodium of 155 millimoles per litre after 4 doses of furosemide. His fluid balance, including during surgery, is 8 litres positive. Adrian is hypernatremic, but does he have a body water deficit? I would argue that Adrian has been over-resuscitated with salt solutions. There's lots of data on this. For example, one paper with 95 patients with severe sepsis found that 29, that was a third of those patients, had hypernatremia within 5 days. There was a strong association between the dose of saline administered and the degree of hypernatremia. Another paper found that the source of hypernatremia was 31% maintenance fluids, 16% boluses, and 12% drugs. A paper from critical care showed that 26% of critically ill patients had hypernatremia, and those patients had previously normal renal function, and it was strongly associated with isotonic fluid administration. Hospital mortality was increased with ICU-acquired hypernatremia, with a very strong signal and absolute risk increase of 18%. And so this is not good, right? These patients who are getting a lot of salt solutions seem to have worse outcomes. I'm not saying this is cause and effect, but it's something that you need to keep in mind, particularly if you're using resuscitation fluids for maintenance. That is not what you're supposed to do. You should be using hypotonic fluids for maintenance. And I will refer you to the first part of my course on fluids for more information on this. If you administer 3 litres of sodium lactate solution in the operating room, there is 130 millimoles or so of sodium per litre. And then you run 125 mils per hour of sodium lactate solution for the first 24 hours as so-called maintenance fluid, the patient will receive 780 millimoles of sodium. That is about 45 grams of salt in the first day. You are essentially curing the patient like a ham. This also does not take into account blood and plasma transfusion, antibiotics and other infusions. And whatever way you look at it, this patient has received 20 times the normal sodium intake during the first day of the acute stress response, and it didn't stop then. So what are the therapeutic options? You can give diuretics that combine loop, that's furosemide, and thiazide diuretics such as metholazone. Now, the problem with this is that inevitably your patient develops profound hypokalemia due to the diuresis and often inadequate potassium administration. Remember, if the patient's been getting a lot of resuscitation fluids, they're grossly undertreated with potassium. You need about the same amount of potassium as sodium per day, and resuscitation fluids have very little potassium in them. In the case of saline, there is none. If hypernatremic fluid overload is causing real problems, hypoxemia, abdominal compartment syndrome, etc., consider using continuous kidney replacement therapy. Now let's move on to another case. You're rounding in the ICU and you encounter Cyril, who's confused, and he is hypernatremic, and you've established that he hasn't had a lot of diuretics. Looking at his labs, his electrolytes are high, his urea is very high, and his serum osmolality is very high as well. So it's true hypertonic hypernatremia. But curiously, when you look at his urine, there is a significant anomaly here. If someone is dehydrated, the urinary osmolality should be spectacularly high. In this situation, it's less than 100 milliosmoles per litre. It's really low. His urinary sodium is also a little bit higher than you would expect, but he is already hypernatremic, so his urinary sodium doesn't really contribute much information. So essentially, the key thing here is that Cyril is not concentrating his urine. What is the diagnosis? The arginine vasopressin system maintains water balance based on serum osmolality and arterial blood volume via the vasopressin 2 receptor. Vasopressin activates the V2 receptor, the basolateral membrane of the distal convoluted tubule and collecting duct of the kidney. This essentially activates aquaporin channels to move into the membrane and open it up and make it porous to water. And that's what happens when water is reabsorbed. When vasopressin is not present, the aquaporin channels sit in the cytosol waiting to be activated. Normally, when a patient is dehydrated, the extracellular fluid osmolality goes up. As a consequence, antidiuretic hormone is produced and lots of water is reabsorbed from the collecting ducts and the distal tubule of the kidney, and the urinary osmolality is very, very high. When a patient has a brain injury, there is damage to either the hypothalamus or the posterior pituitary or other organ systems, and antidiuretic hormone is not produced. So despite the fact that there may be high sodium and high osmolality, the absence of antidiuretic hormone results in low urinary osmolality. And this is known as central diabetes insipidus. And you will commonly see this in patients with traumatic brain injury and sometimes with subarachnoid hemorrhage. The treatment for this is to give the patient desmopressin DDAVP, and this attaches itself to the vasopressin receptors, activates them, opening up those aquaporin channels and allowing water to be reabsorbed. And so as a consequence of giving the patient DDAVP, the sodium and the osmolality fall. Diabetes insipidus is either central due to a brain injury or peripheral, where it's known as nephrogenic diabetes insipidus due to renal tubular insensitivity to antidiuretic hormone. In many ways, nephrogenic DI should be considered a syndrome of ineffective or useless antidiuretic hormone secretion, SUADH. The most common cause of nephrogenic diabetes insipidus is lithium therapy. Lithium interferes with the intracellular reaction that occurs between activation of the vasopressin or V2 receptor and activation of the aquaporin channel, and as a consequence the patient is unable to reabsorb water. And so despite the ADH being present, it just doesn't work, and as a consequence the patient has high sodium, high osmolality and low urinary osmolality. So in the case of someone like Cyril, you really want to have a good look at his drugs that he was on when he came in to make sure that he's not on lithium, and we see this very, very commonly in our practice. There are other drugs apart from lithium that can cause a nephrogenic diabetes insipidus. Methoxyflurane was a notorious anesthetic agent for causing this. It went out of use for many years, but it's back as part of the paramedic service as an analgesic agent. Cisplatin does it. Temeclocycline does it. In the tutorial on SIADH, I mentioned that this can be used to induce a nephrogenic DI in a patient who is maintaining a very high volume status due to inappropriate antidiuresis. It's also seen in electrolyte imbalance, hypercalcemia and hypokalemia due to anomalies that these electrolyte abnormalities cause in aquaporin channels. And it's sometimes seen in some systemic diseases such as sarcoidosis, amyloidosis, mixed connective tissue diseases, and myeloma. The diagnosis of diabetes insipidus is as follows: a polyuria, a large urinary output of more than 40 mils per kilogram in 24 hours. Hypernatremia, low urinary osmolality of less than 200 milliosmoles per litre in central diabetes and between 200 and 500 milliosmoles per litre in nephrogenic diabetes insipidus. To differentiate between the two causes, DDAVP is administered. A response to desmopressin will manifest as a rise in the urinary osmolality in excess of 600 milliosmoles per kilogram, and that confirms central diabetes insipidus. If the patient doesn't respond by concentrating the urine, it's nephrogenic and you need to look for other causes. Let's review this tutorial. In this tutorial, we looked at hypernatremia due to water deficit, ineffective antidiuretic hormone secretion, and iatrogenic salt overload. I looked at how you calculate body water deficit and dehydration. We discussed calculating the quantity and rate of hypotonic fluid administration to normalize sodium. We also talked about how resuscitation fluids are associated with hypervolemic hypernatremia. I finished the tutorial talking about central and nephrogenic diabetes insipidus and why you use DDAVP to make the diagnosis. Next time we'll be moving away from sodium to talk about potassium, and we will initially talk about potassium physiology, hyperkalemia and hypokalemia. Join me then, and I guarantee you'll learn something. That was hypernatremia. I hope you found it useful. If you're enjoying these tutorials, don't forget to subscribe at YouTube or at ccmtutorials.org. I'll see you soon.